Hello everyone, I'm Ali Yılmaz. I'm a pediatric radiologist at McMaster Children's Hospital. I will be talking about hypertrophic pyloric stenosis. Pyloric stenosis is a relatively common disease occurring 1 to 4 per 100 live births. It's a very popular provisional diagnosis in ER and among pediatricians, along with acute appendicitis, variant torsion, and intussusception. It's among the usual suspects in a vomiting infant. However, high negative result rates on ultrasounds, 4 to 1 male to female ratio, typically occurs between 2 to 8 weeks, not usually not earlier than 2 weeks. Uh, Characteristically presenting with non-bilious projectile vomiting, and because of loss of the gastric content, there is resultant metabolic alkalosis, and the treatment is surgery. There is no need to do an ultrasound to exclude hypertrophic pyloric stenosis after 3 or 4 months of age. It starts around 2 weeks of age. So if you see a delayed presentation around 4 months, then that child has to be very cachectic, very debile. We used to see them in the past when ultrasound was not very commonly used and there were missing cases from rural areas. But nowadays, we rarely see a child after 4 months of age. And if you see a request for a 1-year-old baby for pyloric stenosis or a 7-month-old, then you can easily exclude the possibility of hypertrophic pyloric stenosis. If I were to give a historical perspective, I can show you this slide. This patient, this is a study from 2005, almost 18 years ago, and we used to do fluoroscopic studies. At that time, ultrasound was not popular. It was first introduced in the millennium, and nobody knew how to scan the ultrasound, and we were very skeptical about ultrasound, but then we started seeing them. But in the past, we were diagnosing pyloric stenosis by seeing this obstruction at the pylorus. And here you can see there's an elongated pylorus, and the contrast stays in the stomach for hours, and you can see only a little bit contrast passing through after hours. But on the ultrasound, we were able to see the pyloric stenosis directly, and the diagnosis was much easier and faster. If you look at the anatomy, the pylorus is actually normally very thin. There is an antrum of the stomach, and you can't really differentiate the antrum from pylorus in a normal child or in a pyloric stenosis. When there is hypertrophy of these muscles, we see elongation and thickening of these muscles and the elongation of the pylorus. So normally it's a very short segment, the normal pyloric sphincter, but in a child with pyloric stenosis, it becomes elongated. Here is the normal anatomy in an upper GI study. Normal pylorus, very thin, that's the D1, that's the antrum, normal. However, when there is pyloric stenosis on the upper GI studies, we can see this elongated pylorus, this shouldering appearance. This is called string sign. This is shouldering. And we can see the indentation on the antrum as well. This is very typical for pyloric stenosis. And another view, we can see this shouldering and the beaking. This is also called mushroom sign. The appearance of the D1 may resemble to a mushroom. We don't see much on the x-rays and we don't routinely use it, but because the stomach is distended, there is a constant obstruction at the gastric outlet. There is increased peristalsis. The stomach is dilated, and this is, if you see this appearance, it's called caterpillar sign, and under fluoroscopy, there is increased peristalsis like a caterpillar. Ultrasound is very reliable. Sensitivity, specificity, and accuracy rates for the diagnosis of pyloric stenosis is almost 100%. The ACR criteria for the measurements for the muscle thickness is 4 or above 4 millimeter and the length of 18 millimeter. And 3 to 4 millimeter may also be positive, particularly in the premature or younger neonate. So over 3 is abnormal, but if you use the 4 millimeter for the cutoff, then your accuracy rate goes up to 100%. How do we see it? It's here is the normal anatomy. That's D1, that's pylorus, and that's the antrum. The Here, that's the antrum, that's the antropyloric muscle. It's hypoechoic because it's muscle. We can see that if you measure this, it's usually under 2 millimeters, and that's normal. And here is the thickened pylorus, and this muscle, if you measure this, it is thickened, and that's the elongated pyloric canal. That's antrum, that's D1. That's very typical. You can see the pylorus just medial to the gallbladder. The measurements here, the measurement is normally under 2 millimeters. If you measure the thickness from outer to outer hypoechoic wall 4 or higher in the ACR guidelines, and the length is longer than 18 millimeters. However, don't rely on the measurements only for the diagnosis of pyloric stenosis, because sometimes it may be misleading. There are more reliable signs. For example, in this one, that's the pylorus antropyloric muscle. That's D1, that's the antropyloric muscle. If you measure this, it's 3.4 millimeter. Is this pyloric stenosis or not? But if you keep imaging, you can see on another view that the pyloric canal is widened. So here the pyloric canal is collapsed, here widened. So even once, if you see this canal, antropyloric canal widened and open, then you can exclude pyloric stenosis. So you should always look for the passage of the gastric content and opening of the antropyloric canal. Another one, if you dynamically look at the images, here the canal looks a little bit narrow, but here very wide open. So, for example, if you look at only this image, it may look, maybe, is it like a pyloric stenosis? The wall appears thick, but if you look at all the images, you can see in other images the canal is widened, and even in only one image, if you see this, you can exclude pyloric stenosis. Another example, here that's D1, that's antrum, that's the pyloric canal, and you can see the widened antropyloric canal, and it's widened. Even this one, if you have one single image, this you can exclude pyloric stenosis. You don't even have to see the rest of the images. That's antrum, that's D1, that's the passage of the gastric content. You can easily exclude pyloric stenosis. Another example for you here is the gastric content echogenic, and that's D1. So the pylorus is wide open and the gastric content is passing into the duodenum. That's very normal appearance. How about this one? The antropyloric canal appears very narrow. If you measure the muscle, it will be thick. And so this is called antropyloric spasm, or this could be just the normal peristaltic activity of the stomach. And if you continue imaging, you can see that the canal actually is not constantly narrow, and it opens up just like here. You can see the passage of the contrast. Here it's wider compared to this one. So in just one single image of widened anthropoplastic canal, you can exclude pyloric stenosis. So, and it's not uncommon to see that the content actually moves in the reverse direction from duodenum into the stomach. So that's also a sign that the pyloric canal is open. Another example is this pyloric stenosis. It looks like the canal is very narrow. If you measure the wall thickness, it reaches up to 3.9. It's actually thick by measurement. But if you keep looking at the other images, you can so still not opening up. Here some contrast, some gastric content passage. It's more convincing. And here on the later images, you can see wide open pyloric canal and passage of the gastric content into the duodenum. So you can easily exclude. That's why you shouldn't rely on the frozen images and only the measurements. There is not much differential. Another sonographic finding is double track sign. It was originally described in upper GI studies and now used also for ultrasound too. These are two parallel echogenic lines caused by mucosal folding in an elongated pylorus here, just like this one. It's called double track sign. It's also a sign confirming the diagnosis of pyloric stenosis. So for take-home points, rely on age. The age it starts between 2 to 8 weeks, and question your diagnosis if it is positive for pyloric stenosis under 2 weeks and over 3 to 4 months. Ultrasound is highly accurate, and you should be confident to send the patient to surgery with your sonographic findings. Don't rely on the measurements only. Try to see antral and pyloric opening and content passage, and make sure that there is no antropyloric spasm. Thank you for watching.